All right, everybody, welcome to Grand Rounds for October. I'm very excited about this one. I'm just going to do a couple housekeeping things real quick and then turn it over to the docs. As always, this is recorded. We are going to share it, post it. CME questions will be available after when we get that uploaded for anybody that wants to submit for their credit. Please put all of your questions in the chat, but we are going to address that after Dr. Carla finishes her presentation. Since we're really excited about it, we'll go through those at the end, and away you go, you guys.
Awesome. Thanks, Jen. Well, it is my great honor and pleasure to introduce Dr. Carla DiGiralomo, who I've gotten to work with over the past number of years. And Carla has always been extremely gracious with her time and clinical expertise in ways that go above and beyond. So she's not only an outstanding clinician, but an amazing friend. And so it's really fantastic to have Carla here. She is really a world-class expert in the area of women's hormone health and performance. And I'm sure I'll butcher this, but your area of expertise and focus these days is on kind of health and performance optimization from puberty through menopause. Is that correct? And through the other
side?
That's
exactly right. Yep, that's right.
Carla is an OB-GYN by training, but she's also boarded in reproductive endocrinology, and I'm sure she'll talk some about this, but went on to get certification through the North American Menopause Society. So she's also NAM certified. So has an extensive clinical background and has worked clinically in reproductive endocrinology for, past 18 plus years. So it's a true honor and privilege to have Carla here with us. And she's going to do a presentation on low energy availability and relative energy deficiency syndrome this evening for us, which we're super excited. And Carla has said that she's going to make the slides available for us because there is a lot of information on those. So if you do have interest after the fact or would like to get your hands on some of these graphs or diagrams or slides, we'll make it available through reaching out to us so that we can get you that information. But without further ado, I will turn it over to you, Carla.
Thank you, Tom, for that wonderful introduction. And thanks to everybody joining tonight and taking time out of their day. I'm going to try to share my screen now. I'm not the most technologically savvy, but let's see how we do.
Looking good. We got it.
Excellent. Okay, great. So I wanted to first start by talking about why this is important. And hold on, I'm going to move the little square so I can see my slides. There we go. So inadequate fueling is a real problem in female athletics. And I'm going to show a slide pretty soon on some actual statistics about that. Female hormone physiology is closely tied to energy balance. And we're going to talk a lot about hormones a little bit later. We all know that inadequate fueling compromises physical performance, and prolonged energy imbalances can result in serious health issues. This problem impacts females across all age groups and over a variety of athletic activities. Okay, trying to advance my slide.
We'll see, Jen, are you able to help her at all? Or I don't know if you can, huh? If we don't have it.
I don't have it. We worked yesterday. Are you on the screen? Do you have the screen up to actually move it?
I do. Let me stop sharing it and let me go back in again.
Okay.
It could be just a little glitchy. Let me just go here. Okay. Can you all still see the screen or no?
Not yet.
Okay. Let me just do end show. And let me go back to the WebEx and let me share again. Okay.
Okay, we can see it now.
All right, great. And I'm going to go on the current slide. All right. All right. That works.
Yep.
I'll do it manually.
There we go.
So energy availability, what is it? It is the dietary energy that's left over and available for optimum function of the body systems after accounting for energy expended from exercise. So mathematically, energy availability equals dietary intake minus energy expended over fat-free mass in kilograms per day. Now, when energy availability is low, or LEA, there is a mismatch between dietary energy intake and energy expended, leaving the body's physiological needs for maintenance unmet and unable to support optimal health and performance. Now, when LEA is severe and prolonged, it can result in relative energy deficiency in sport, or RED-S. And this is a syndrome of impaired physiological and or psychological functioning experienced by both male and female athletes, again, when it is severe and prolonged. So it's a spectrum. LEA in RED-S exists on a spectrum. LEA in its milder form can be adaptable, meaning it's short-term, reversible changes in physiologic biomarkers, minimal to no impact on long-term health and well-being. And an example of this could be a weight class athlete or a physique athlete, someone who needs to achieve a certain weight to compete or a certain aesthetic. And so they go into low energy availability prior to the competition. And then once the competition is over, they go back into a more sustainable, balanced state. And this doesn't tend to have too much adverse impact over the long term. However, when it is prolonged and severe, it becomes problematic LEA or RED-S. And this is a maladaptive response of the body to this energy deficiency. It can cause persistent disruption of bodily systems and a negative impact on long-term health, mental health, well-being, and performance. And so here's a list of some of the health consequences of RED-S. And most notably, there's a whole list here, but menstrual cycle dysfunction, infertility. And what I can tell you as an infertility specialist for many years is that I could see a lot of women who were collegiate athletes who were in RED-S during the time that they were most competitive. And even when the energy balance is restored, many times that menstrual function and fertility is not. So that doesn't mean that happens all the time, but sometimes even when you correct the energy imbalance, you still have persistent issues. Musculoskeletal health, bone density becomes an issue. And again, there's a whole list of other things that can be problematic. So the prevalence of LEA and RED-S, overall prevalence in female athletes ranges between 23% and 79.5%. Males, similar big wide range. And the reason for this is because different sports have different prevalences of LEA within them. So you can see volleyball players are at the lowest in this particular reference that I have on the slide at 20%. And endurance athletes, it can be greater than 50%. And I know that I've seen other studies where over 80% of the endurance athletes studied were in persistent LEA or RED-S. So it can be very, very prevalent depending on the sport. So the factors that lead to LEA and RED-S, this is taken from the IOC, International Olympic Committee 2023 consensus statement on RED-S. And this is an awesome, awesome article. I think anybody who takes care of women should have this at their desk side because it has some very helpful tools in it. But if you review that article, the studies have shown that inadequate carbohydrate intake is a huge, huge contributor to LEA and RED-S. Other contributors, as Stacy Sims has said, women are not small men. There's lots of research on fueling men, and because there's not so much research on fueling women, a lot of what we learn about men has been applied to women, and that hasn't worked out so well because physiologies are very different between males and females. The demands of the sport. Weight class athletes, as I mentioned, can have certain competitive and aesthetic requirements, as well as you think about triathletes, endurance athletes who have competitions that are very long in duration. Their training sessions are very long in duration. So those are very high volume training types of sports. Disordered eating and clinical eating disorders, we find a lot of this in the athletic population, especially in elite athletes where, you know, that personality type that drives them to be so successful and in their sport can also be associated with obsessive eating and training tendencies. Now we're going to talk about hormones. So the female human body was designed for the physical demands of procreation and for survival. And procreation and survival are the most powerful forces that drove the evolution of the human race and continue to drive the existence of the human race. So let's talk about the physical adaptations that the female body has. And pregnancy is an excellent example of this. So in pregnancy, cardiac output increases by up to 50%. That's incredible amount of increased volume in the body. And the vasculature and the heart have to adapt to this increased volume so that it doesn't go into failure. Chest size increases to preserve lung capacity because as the baby is growing in the abdomen or in the uterus, the diaphragm can't move as readily to expand lung volume. So the lungs have to expand in a different direction. And so the rib cage accommodates this. The immune system it changes dramatically because it has to protect the baby against rejection from the mother. And it also has to keep the mother healthy and be able to fight infections. And then when the baby is born, and the placenta and the baby are separated from the mother's body, there is an instantaneous readaptation of the cardiovascular system that has to occur now that there's all this volume that was perfusing the baby in the placenta, and now it's gone. And so this readaptation has to happen again to prevent the body from going into heart failure. So if that isn't mind-blowing enough, women across the spectrum of health, so some of the seemingly most unhealthy women pull off these physical adaptations without a hitch the vast majority of the time. So that just shows how powerful this is, this wiring that we have hormonally for procreation, because across the spectrum of health, from poor health to excellent health, women seem to undergo these adaptations successfully the vast, vast, vast majority of the time. So why are we talking about pregnancy? Because it's, again, a prime example of the ability of the female body to adapt to a physical challenge. And we think about what physical fitness is. It's the ability to effectively adapt to a wide range of constantly varying physical challenges. So by aligning training, nutrition, and recovery with what nature has already put in place, the potential for physical adaptation in the healthiest, physically elite females can be taken into the stratosphere. So this all begins at puberty. And puberty is the transition from female reproductive quiescence to reproductive competence. So we know that adequate body fat percentage is necessary for menstrual cycles to begin. And we've all seen examples of the teenage gymnast who just doesn't get her period. She's 16, she's lean and athletic. This is a very well accepted thing. There has to be a certain body fat percentage for menstruation to happen. And then there are a number of hormones that exist out in the periphery to signal to the brain what the energy and nutrient status is in the environment and in the female's body. This is leptin, kisspeptin, and ghrelin. And so this is a pictorial of how they interact. So kisspeptin is secreted in the hypothalamus. Leptin resides in adipose tissue, so it's sending signals about stored energy in the female body. Ghrelin is found in the stomach, and it's sending signals about nutrient availability. So all of these foot soldiers in the periphery is sending signals to the brain to say, hey, energy is good. You know, we've got adequate stored energy in the environment's coming in, all is good. And the brain says, great, let's have a baby. And so the hypothalamus secretes gonadotropin releasing hormone. That talks to the pituitary. The pituitary tells the ovary to make an egg, and then the ovary tells the pituitary to ovulate, and now pregnancy can happen. So that's kind of how the whole energy availability equation works and how it affects the reproductive system in response to nutrient and energy availability. So on the right, we've just talked about procreation. Now we're going to talk about survival. And survival, endocrinologically, is driven by the stress response system. This is your sympathetic nervous system. This is your fight or flight response. And as you can see, it's a parallel thing. It involves the brain, it involves the pituitary gland. So the brain is taking in stimuli from the environment. It sees the bear in the woods, so it perceives a threat. And so it sends signals via the brainstem and the hypothalamus to the pituitary gland to secrete ACTH, adrenocorticotropic hormone. This tells the adrenal glands, game on, there's a threat, let's start secreting hormones and get the body ready to fight off the bear in the woods. So we have cortisol, we have testosterone, epinephrine, norepinephrine, and aldosterone that have system-wide effects to get the body ready to fend off the threat. And the immune system also gets ramped up in preparation for wound healing if one sustains injury during the fight. And so, again, Mother Nature was smart, because when there's a bear in the woods ready to eat you, it's probably not a good idea to be procreating. So when the stress response system is ramped up, it tends to have a negative effect on the procreative hormonal axis, because it's just not a good idea to have a baby when there's a bear in the woods. So that's kind of how the survival and the procreative pathways work together. Now, we're just talking about menstrual cycles. This is kind of a summary. We know from the previous slides that these are the foot soldiers that talk about, or that send signals about energy availability, nutrient availability to the brain. If it's not there, it's going to tell the menstrual cycle, it's going to tell the hypothalamus, nope, there's not enough energy, there's not enough nutrients, not a good idea to procreate, we're not going to have periods. Similarly, if there's a bear in the woods, if there's a stress in the environment, that's not a good time to have a baby either. So that is also going to downregulate the reproductive system. Now, in midlife, we're going to talk about perimenopausal and menopausal women. Those menstrual cycles are becoming more infrequent, and in menopause, they have stopped completely. And Stacy Sims talks about this so eloquently, is that the menstrual cycles and the hormones of the menstrual cycle create this buffer, and it gives us resiliency in handling the stress response system. And when that menstrual cycle hormonal buffer is no longer there, in midlife, when there is not so much energy available, it has a beeline right to the stress response system. And this is why when we are persistently in LEA and RED-S, particularly in midlife, this can create inflammation, this can create a ramp up in the fight or flight system and cause all kinds of problems. So in midlife women, because they don't have that hormonal buffer, the low energy availability can have a more amplified effect on the stress response system. So the wiring is still there, even beyond the age when procreation is going to be happening. So LEA and RED-S, hopefully I've convinced you that this is important. And so how do we know if our patients are struggling with this? So in the article that I referenced, there is a tool called the RED-S CAT2 Severity Risk Assessment Tool. And this is really helpful because it categorizes certain parameters, historical and objective laboratory parameters, in certain groups, and it gives certain weights to them, and it creates this system of like red, yellow, and green sorts of risk categories to help you figure out where is your patient on that spectrum. And so the history is very important. We have to talk to our patients. I know in this age of tech, we do less of that, but really it helps to understand the nuances of what she's experiencing. Menstrual cycles are one of the highest correlates with energy availability, and I just demonstrated the hormonal reasons why. So if a woman comes to you and says, well, I used to have regular periods, I started training for the marathon and now they're gone, that's a clue that, okay, we have to start considering energy availability or energy imbalance. We need to ask them about training schedules, food logs, and you should ask everybody, because I can tell you that people who look like just regular people can be really badass competitive athletes. I have an 81-year-old woman who just ran her 200th triathlon, and she just looks like this little old lady, but she's done 200 triathlons and she's still doing them. She's doing sprint distances now, but she's still doing them. So you need to ask everybody, even if they don't quite look like athletes, they just very well might be. You want to ask them about injuries and fractures. Sleep's very important. What's their mood like? And then testing more objective parameters, IGF-1, iron studies. You want to look at their blood sugar. You want to look at their vital signs. Sometimes morning cortisol can help, and inflammatory markers such as CRP can be helpful as well. So, okay, we have identified that our patient is at risk and she is in an energy imbalance. So how much fuel is enough? Well, it's not so straightforward because there's no one size that fits everybody. And there's a lot of reasons for this because there's a lot of variables. One is that there are genetic factors. People metabolize carbohydrates differently. Some people are more tolerant to them and some people are not. Age, big factor. A 50-year-old woman is going to utilize energy much differently than when she was in her 20s. Menstrual cycle phase. So as a generality, pre-ovulatory tends to favor carbohydrate. Carbohydrates can be used very efficiently in the pre-ovulatory phase. In the post-ovulatory phase tends to shift toward fatty acid oxidation. So there can be some variation there. The type and volume of physical activity. Is your patient a power lifter or is she a triathlete? Very, very different training and physical challenges with those two sports as examples. Morphologic body type. Are they an endomorph? Do they just look at protein and pack on muscle, or are they ectomorphs where no matter what they do, they just can't increase their muscle mass? So lots of variables here, but there are still guidelines. And so in the article that I referenced, they talk about this study, and it's a study in sedentary females. So you might feel like, well, this doesn't extrapolate to my active women or athletes, but bear with me because it really is relevant, and I'll show you why. So in these sedentary females, they looked at various ranges of energy intake in kcals per kilogram per day. And what they found was that mass gain and growth happened at over 45 kcals per kilogram per day. Maintenance of body weight, bodily function happened at about 45. Body mass fat loss happened between 30 and 45, and 30 was what they defined as the threshold below which significant health issues can occur. So how does this translate into a typical patient? So if you take a 130-pound woman, 20% body fat, it's pretty average. Fat-free mass, I calculated already, it's 47 kilograms. So if we put this in the equation, 47 kilograms times 45 kcals per kilogram per day is 2,115 kcals per day for maintenance and growth. This is in a sedentary woman. Okay, so you know your athlete is going to need more than that because she's not sedentary. Similarly, let's look at 35. This is kind of in that weight loss, mass loss. That's about 1,600 calories a day. When you're kind of at that danger zone, we're looking at 1,400 calories a day. And did I mention the study was in sedentary females? How many marathon runners have we seen who come into us training on 1,400 calories a day? So this just kind of gives a perspective of what kind of energy intakes we really should be striving for in our athletic patients. And, you know, culturally, there's this carb phobia that we've been dealing with for a very long time. And my own knee-jerk reaction when I did this out, I'm like, how can this be right? It's what the studies show, or what this particular one is showing. So it's kind of a wake-up call, or it should be a wake-up call to all of us, that a lot of our clients are really not fueling enough. Now, in midlife women, this is tricky. And this is what the newsletter was focusing on, is that the symptoms of LEA can look like the symptoms of perimenopause and menopause. This is not just an athlete problem. I can tell you that about half, if not more, of the midlife clients that I see are not eating enough, at least half. They see these body changes happening that just go along with hormonal change. And they describe it as very dramatic. It's like, well, I went to bed and I woke up in another person's body. I can't tell you how many women have said this to me. So what happens is they panic, they eat less, they train more, they've got this fat around the middle that's really bothering them. And some of the old disordered eating patterns, if they grew up in the 80s, like many of us did in the 50, who are in their 50s and 60s, go back to that thin as in sort of really dysfunctional diet culture that they grew up with. And so sometimes it's very hard for these women to get their head around eating an entire plate of food at once. So these are some of the challenges that we face in midlife. And so here's a vignette to kind of demonstrate what those symptoms can look like. So Gina is a 47-year-old female who presents to discuss her perimenopausal symptoms. Over the last 1 to 2 years, her menstrual cycles have become irregular, with intervals every 2 to 3 months. She describes sleep disturbance that has increased over the last 6 months, along with brain fog, mood irritability, joint pain, and low drive. She reports a stubborn 5 to 10 pounds of fat around her middle that she can't lose no matter what she does. She's tried intermittent fasting, nothing's working. She states she occasionally feels hot, but denies hot flashes. She denies urinary or vaginal symptoms. She's seen her PCP for these symptoms, and they told her it was perimenopause and offered her birth control pills. She presented to me for a second opinion. So here's some of the objective data she came in with. She's 5'7", 130 pounds, so she's lean. Heart rate was 52, resting, blood pressure 90/60. Lab values, her FSH is 85, E2 is 15, progesterone 0.1. So she's clearly perimenopausal. She's 47, she's got irregular periods, and she's got an elevated FSH. So yes, she is perimenopausal. Testosterone is in the normal range for this stage of life. AMH is what is expected in this age group. Thyroid functions were normal. Her lipid panel, total cholesterol is 235, LDL is 145, HDL is elevated at 97, triglycerides are 73, and her A1C is 5.7%. Fasting insulin is elevated at 9. So being a little panicked about the high LDL and the cholesterol, she had a coronary artery scan done. Her score is 0. Her arteries look pristine. Her CRP is elevated at 2.5. Ferritin is low at 28. Now, I see this lipid pattern a lot, and I don't believe that it has anything necessarily related to energy availability per se, but it is a common trend that we see in these athletes in this age group who are female. And so many times when you do that coronary artery scan, their vessels look fantastic. So please don't put them on a statin. Their vessels are fine. This is a phenomenon that we are tending to see in these athletes. But what I really want to focus on is the glucose intolerance. So this is another trend that I've been seeing a lot in my patients. And I actually reached out and communicated with Stacy Sims directly about this past week, anticipating this Grand Rounds. And I told her, I said, I am seeing a lot of this. Is this a thing? And she replied back to me, yes, it is a thing. And we see it a lot. It's like a paradoxical glucose intolerance in response to this persistent energy imbalance. And so the leptin system is involved. So the leptin isn't just sending signals about fat availability. It is also sending signals about carbohydrate availability as well. But the physiology on that's a little fuzzy. But when the stress response system is chronically activated because there's that chronic stress in the environment, the body is liberating glucose into the system to fend off the threat. And so what you have is this paradoxical increase in your blood sugar levels, not because it's insulin resistance or glucose intolerance necessarily, but it's just this chronic activation. So what happens a lot of times is we strap a CGM on them and we start restricting their carbs, which is making the LEA worse. So even though it's counterintuitive, these women who are clearly in LEA, we need to not be fearing the carbohydrate, because if you restrict them more, that problem is going to get worse. But if you actually feed them the carbs, this whole thing will normalize. So I just wanted to go off on that tangent because it is an observation that I've been seeing, and according to Stacy Sims, it's something she's seeing as well. So training and nutrition. So do you exercise? I asked her. She said, yeah, I'm a lifelong marathon runner and I'm training for the Boston Marathon. I train 10 to 12 hours a week, mostly running, biking, sporadic weight training during the race season. She's tracking nutrition. She's taking in 1,200 to 1,400 kcals per day. She gets about 125 grams of protein, and she's not sure about her carbohydrates. So clearly she has an energy imbalance. So what we did some sleep tracking. It's important to do that, I think, because you never know, even when a lean person has obstructive sleep apnea. So you do want to identify that if you can. We incrementally, and I want to stress incrementally, increase her total caloric intake, with the goal being 2,000 to 2,200 to start. She probably needs more than that, but when you're only getting in 1,200 to 1,400, you can't build Rome in a day. So you really have to be incremental, especially if there is some psychology surrounding the eating patterns. Nutrient timing is a great way to focus the carbohydrates around the time that the body is looking for fuel. That's about an hour before the training and about an hour after. And also, if there's a psychology surrounding more food intake, people can wrap their head around, oh, okay, I can eat more before my workout because I'm going to burn it off anyway. And I'm still burning fuel after I have my workout. So, okay, I'm on board with increasing my carbs during that time. So when there's a psychological component, something that's a really good way to start. And then when they start feeling better, you can now start adding carbohydrate and energy at other times of the day. They won't be so fearful of it. So that's how I like to start that in somebody who I think may have some disordered eating tendencies. And of course, in midlife, you know, when the hormones aren't cycling the way they used to, we don't recover the way we used to. There's more inflammation around. So you want to make sure they get their mobility, their yoga, cold plunges, tissue care, etc. That needs to be front and center in their routine, especially when they're elite level athletes. So after about 3 months, and this is an ongoing process, her sleep subjectively improved. She felt more rested upon awakening. She had less joint pain. She subjectively improved performance, increased her desire to train, less irritable and more clear during the day. She just overall feels a whole lot better. And lo and behold, her belly is starting to flatten out. She still feels hot at night, but it's not disrupting her sleep. So in this patient, she is indeed perimenopausal. But the symptoms that were disruptive to her were not because she was perimenopausal. They were because she wasn't fueling adequately. And once we started to improve that situation, those symptoms started to improve. And then the one symptom that is probably related to her perimenopause that isn't really going to be necessarily impacted by energy availability is the feeling hot at night. But it's not disruptive to her, so we don't need to be giving her hormones. So this is an example of how perimenopause and LEA can look similarly, and how we can't just assume because they're perimenopausal that their symptoms are because of their perimenopause. It could be because of fueling. So in the midlife population, some special considerations for fueling. We have to know that LEA is a problem in these ladies as well. And so we can't discount that. The absence of cycling reproductive hormones leaves the stress response system more sensitive to the effects of inadequate fueling. Fasting more than 12 hours should be avoided. Training fasted should be avoided in midlife women without obesity or metabolic disturbance, because according to a lot of the research, Stacy Sims writes a lot about this, is that unless one is obese or has metabolic disruption, this is not helpful for active women. It can cause hormonally more harm than good because that intermittent fasting or training fasted just exacerbates the stress response system's response to not having the fuel around when it's looking for it. Adequate protein never been more important than it is right now during this midlife phase because of declining bone density and muscle mass. When the body is recovering from training, it needs those building blocks to repair and restore. Creatine has many benefits in active women, cognitive benefits, musculoskeletal benefits. And again, nutrient timing is an excellent strategy to try to get that extra caloric intake and macros into their system. And just to summarize the whole talk, females are programmed by nature to be highly sensitive to energy availability. LEA and RED-S is a significant problem in female athletes at all ages. Prolonged LEA and RED-S can lead to significant and sometimes irreversible health problems. Inadequate carbohydrate intake is a big culprit in developing energy imbalances. And an awareness of the risk factors, mental health and behavioral considerations is so important in identifying these women who are in an energy imbalance. And the approach to them needs to be individualized and it's multidisciplinary. You've got your friendly endocrinologists like myself, you have your trainers, your nutritionists, your coaches. Everyone needs to work together to optimize the care of these women dealing with this very complex problem. And lastly, midlife women are at particular risk for the adverse health effects of inadequate fueling, and they require additional considerations relative to reproductive age women. So with that, I thank you. I hope you're all still awake, and I'm happy to take questions.
Carla, that was fantastic. As you alluded to, chock full of information. I mean, a couple of thoughts that struck me right out of the gate is how easy it would be, referencing the vignette that you highlighted for a perimenopausal woman to go into their PCP and just being diagnosed with menopausal symptoms and be giving an oral contraceptive pill with, I would assume that the vast majority of the time, 90+%, that there's no nutrition history obtained in those situations. And as you alluded to, if somebody doesn't quote unquote look the bill of an athlete, it would be even easier to miss. So I think it's such an important point for us to remember and understand that really should be a standard component of our history taking. And I think it's so fascinating too, because of the counterintuitive components of those labs, right? Like somebody could look at that fasting insulin or that A1C and think, oh, there's a carbohydrate issue. But there are clues in there, right? I mean, you look at the ferritin and you see a functional deficiency. It's like that should raise a red flag that there could be a larger nutritional deficiency despite an elevated fasting insulin. And the funny part is those of us that do this for a living know that a fasting insulin of 8 is abnormal, but the normal quote unquote range on the lab assay goes up to 25, which is unbelievable, right? So really working with somebody who understands what these numbers mean and what they reflect and what optimal is, I think is really important. So there's so many pearls and golden nuggets in there to take away. I really, really appreciate the expertise. Any questions from the gallery?
Not questions, just a kudos to a great job from Ron. Thanks, Dr. Ron. I just wanted to comment as, I know Grand Rounds welcomes in the providers to join live and offers a CME. We do share this information with, the affiliate owners that are part of the medical society as well. And I think that it's a really important topic to shed light and understanding as affiliate owners are kind of digging into wanting to not only connect with providers that can support their members, right, in different phases of their life's journey, like in their tenure at the affiliate, but then also to give background to, some of the struggles and, bring a level of compassion to what females might be going through in the gym and in the gym space, like as they go back and forth through, all these different phases. And, Tom can share a little bit on this if he wants to, but our affiliate is this demographic, right? So like we are a middle-aged affiliate. We've been open for 10 years. Our members that started at 39 are now 49. And so it's a very real discussion that understanding how to support them, and create a space where they feel comfortable talking to their coaches and identifying things that might be going on in their life, and then knowing how to refer them to the specialists to help them. Like, it's a very, I feel like as an affiliate owner, that's a really important role that we can, that we can absorb and then support our members in that way. So
Yeah, I think it's such an important topic to make everybody aware of. Carla, we should all connect you with CrossFit too, to maybe do a rest day email to talk about this. I mean, just like, is it really your hormones? And just talk about the importance of fueling, because that is the natural progression, right? You have these body composition changes. It's like, I need to eat less and I need to do more fitness, right? And it's just this negative feedback loop that progresses on itself. And it would be extremely easy to not recognize that yourself, but we really need to let all of our coaches know and our community know, especially our relationship as a community to carbohydrates, right? And how, historically that's been viewed, to be able to make sure, one, that we're just fueling enough overall, and that we can recognize this over the short, medium, and long term. So I think it was a fantastic presentation. So I really appreciate the time and expertise. All right. Anything else before we wrap this up?
There's just a couple comments swirling around, like the notion of encouraging patients to eat more,
Mm,
and then kind of filling the pipe dream where, it's tougher than we think it is to live in that it's okay to eat more world, right? Like, that's, not necessarily how we're conditioned to do, especially I think more or less, right? In the context of, obesity being at the front and center of what everybody's thinking about from a chronic disease standpoint. And then here we are, that we have a whole batch of chronically underfueled women, right, that are kind of on the opposite end of the spectrum, that have to have a very different mindset on how to support their health in the most optimal way.
so true.
I mean, I can tell you from experience, I am one of these women. I'm 54 years old. I was 15 years old in 1985. And it's real. I mean, I struggle with it too still, I mean, and I never really had any clinical eating disorders, but it's just there because it's hammered into you in a very impressionable time of your life. And then even when you put that to rest, it rears its head when you start having that same awkwardness as a teenager of your body changing and not realizing why. It just takes you right back there. And it was a really, really difficult time to be a teenager and to be female. For sure. And, just to follow up on one thing you said, Tom, in the very beginning, which is so true, is that in the general medical community, this is like not sports medicine people, because sports medicine people understand what LEA is. They don't even know what LEA is. I can tell you, I confess that I didn't know what LEA was until I started working with athletes. And I had to teach myself about this because I went through residency training, fellowship training. I never knew what LEA was, and I was an athlete my whole life. So if I didn't know about it, I can imagine how the rest of the community probably doesn't even know what those letters mean.
Yeah.
So I think we have to know that when they're coming to us from the outside world, of just no one, I'm sure, has even asked them what kind of exercise they do, let alone ask them about energy balance.
Well, and I think a lot of practitioners have the misunderstanding that it is an issue of the young athlete as well.
Exactly.
And that lack of an understanding that it really can track throughout your life cycle, kind of, and regardless of what your presenting body composition is, right? And so remembering to keep that on your differential, right, for anyone that comes into you, regardless of where they are, what kind of athlete they are, like we need to check ourselves every time we walk in to a room in that regard. Because I mean, my experience clinically is just like yours. I mean, I can count on one hand, in all likelihood, the number of women who were not under fueling, who are struggling with body composition that I see. I mean, all of them, almost to a T, are under fueling, right? And it just propagates the cycle, and it's such a diabolical misunderstanding on a societal level for us. because as you alluded to, it's so hard to start to see and view and understand and have a different relationship with food and fueling and how that impacts you. And so education is a huge part of that, which I think was why this is so important. So really appreciate the time, Carla. It was fantastic. And I look forward to sharing it with the broader community.
Thanks,
All right.
Tom. Thanks for the opportunity.
Yeah, I know we're coming up on time. Jen, anything else before we go? Any housekeeping stuff?
I think that is it for now. I just also want to extend my gratitude to Dr. Carla. So, it's an important topic to continue to shed light on. And I think too, especially as CrossFit as a sport is now part of the lives of people at a much younger age, right? Like I started this when I was in my late 20s, but you have teens, like my son's 11, he's doing CrossFit, right? We have young girls doing CrossFit now. So it's going to be part of what hopefully they do for a long period of time. And so awareness around how to maintain it as a lifelong modality for health and fitness on this like big spectrum of health that we continue to talk about is really important in its own context too. So
yeah, really
Sure.
good point, Jim. Okay, everybody. Well, really appreciate folks tuning in. And again, thank you, Dr. DiGiralomo, for your time and expertise and being gracious as always. And we'll get this out to the community, and I'm sure there'll be more questions to follow up. And if folks want access to some of the slides or data that Carla presented, feel free to reach out to us at the Medical Society, and we can do our best to get you the info. All right.
And feel free to make my email available. I'm happy to, if anyone wants to curbside me or anything, I'm happy to help the community.
Oh, thank you, Carla. That's
thank
very
you so much. All right, you guys, I'm going to stop the recording.